intraduodenal part. Okay, like this 4 parts are there, and ultimately it is draining into the second part of the duodenum. Telling you this again because throughout the length of the common bile duct or the other ducts, whatever we have discussed, okay, a very important clinical aspect is related to that. Okay, have you heard about jaundice? I hope you have heard about jaundice, and I hope you have seen people suffering from jaundice. Okay, so 3 different types of jaundices are there. Among them, one is the obstructive jaundice, where the obstruction is taking place in the flow of the bile. That means obstruction is taking place over here in the extrahepatic biliary system. Okay, due to that, the bilirubin level increases in the blood. Okay, so that's why the thorough knowledge of the biliary system, especially the extrahepatic biliary system, is important. Okay, so whatever we have discussed that day, after that 2 parts were left, that is the blood supply and nerve supply of extrahepatic biliary system. Biliary system ducts are there, okay, and you have seen sphincters are also there in the extrahepatic biliary system, and sphincters are very important because they are controlling the flow of bile into the second part of the duodenum, okay, in the extrahepatic biliary system. So the blood supply is important for that, and then the nerve supply is also important because those sphincters are controlled by the nerves only. Okay, along with that, other factors are also responsible, but mainly the nervous system are there which is controlling the opening and closing of the sphincters. Okay, so first we will see about the nerve supply, the blood supply of the extrahepatic biliary system. Okay, now in the blood supply, I have mentioned that 2 things are there, that is the arterial supply and venous drainage. Okay, in the blood supply of extrahepatic biliary system, 2 components will be there. First is the arterial supply and second is the venous drainage. Okay, so as you can see, do you remember this diagram? Forget about the blood supply. What is this? Gallbladder. What is this? Cystic duct. Okay, these are hepatic ducts, right and left hepatic duct. Then this is the common hepatic duct, and then this is the common bile duct. Okay, as you can see, they are draining into the second part of the duodenum. Now before draining, it is joined by main pancreatic duct. Only the pancreatic duct is shown over here. Okay, the pancreas is removed, only the pancreatic duct is shown so that you can see how they are uniting together before termination. Okay, now in blood supply, as I said, 2 components are there. What are these 2 components? Arterial supply and venous drainage. Now in this diagram, you can see the blood vessels which are supplying the various part of the extrahepatic biliary system. Okay, now which is the main artery which is supplying the most of the biliary system? Okay, can you see the artery? This is the cystic artery. Okay, cystic artery. So cystic artery is the chief source of the blood supply. Okay, for the extrahepatic biliary system and also for the gallbladder. Now this cystic artery which is there, as you can see, this is the cystic artery. Okay, so the cystic artery is mainly arising from the right branch of the hepatic artery, okay, which is nothing but the branch of celiac trunk only. It is supplying the gallbladder, upper part of the cystic duct, hepatic duct, and upper part of the bile duct. Okay, these are supplied by cystic artery. Okay, so cystic artery is supplying the gallbladder, cystic duct, hepatic duct, and the upper part of the bile duct. So these are the areas which are supplied by the cystic artery. Okay, next several other branches are also there. You have to understand one thing: whenever a tubular structure is there, one source of blood supply is not sufficient. Okay, whenever it is tubular, because in case of tubular it is extending. For example, now here you can see the tubular structures, all the ducts are nothing but the tubular structure, so they are extending. So this upper part, okay, you can see this upper part can be supplied by the cystic artery. Okay, what about the middle part and the lower part? So it is not possible for the cystic artery to supply the entire structure, okay, because it is tubular and it is extending from one part to another part. Okay, that's why always in case of tubular structure, additional blood supply is required. I'll give another example. When you will study the esophagus, esophagus is also a tubular structure. Okay, approximately 25 centimeter long. So in case of esophagus also we will study that blood supply for upper part, middle part and lower part, it is separate, it is not same. Okay, so why I am mentioning, because these points will help you to remember the things and write exactly during the time of exam. Okay, don't just write only cystic artery. No, cystic artery can't supply the entire part. So other parts are also there. Now how the other parts will be supplied? Several branches from the pancreaticoduodenal artery will supply the lower part of the bile duct. Okay, so as you can see, superior pancreaticoduodenal artery, some branches will supply the lower part of the bile duct. Now right hepatic artery are giving some minor branches which will supply the middle part of the bile duct. Okay, the right hepatic artery will give some minor branches which will supply the middle part of the bile duct. Okay, so this is how the arterial supply is taking place in case of extrahepatic biliary system. Okay, so we have divided the extrahepatic biliary system upper part, middle part and lower part. Okay, and in each and every part the blood supply is different. So after arterial supply, what is the next point? That is the venous drainage. After arterial supply, next point is the venous drainage. Okay, now in case of venous drainage, it is not that simple. Okay, two venous plexuses are there. As you can see in the diagram, the venous plexuses are there. Okay, now the veins draining the common bile duct are arranged in the form of two plexuses. Okay, now what are those two plexuses? As you can see, epicholedochal venous plexus and paracholedochal venous plexus. Epicholedochal and paracholedochal venous plexus. Epicholedochal venous plexus, they are present at the surface. Okay, and paracholedochal venous plexus lies outside the ducts. Okay, and the paracholedochal is situated parallel to the common bile duct. Okay, so that means mainly the venous blood is drained by these two venous plexuses. Now from these two venous plexuses, the inferior marginal vein is also there and superior marginal vein is there. Okay, now this inferior marginal vein will communicate with the gastric vein, posterior superior pancreaticoduodenal vein, gastrocolic trunk, and superiorly it will enter into the hilar plexus and then eventually it will drain into the portal vein. Okay, now last time I hope you remember we have discussed about the portal vein, and I have told you that most of the GIT, okay, except the lower part of the rectum, most of the GIT is drained by portal vein. Okay, so here also these are the part of GIT only, offshoots of the GIT. So ultimately the blood which is coming out, the venous blood, they will go to the portal vein, and from portal vein they are going to the liver. Okay, so as you can see, the plexuses which are present, ultimately you can see the hilar components are there of the epicholedochal venous plexus, and then they will drain into the some tributaries of the portal vein. Okay, so in case of venous drainage, two venous plexuses are there. Okay, now from these two venous plexus, whatever blood is draining, okay, superiorly and inferiorly the direction is different, but ultimately they will reach into the tributaries of portal vein, and from portal vein they will go to the liver. Okay, next is the nerve supply. Now what are the points which I have mentioned about the nerve supply? I don't know whether you have noted it down or not. Okay, in case of nerve supply of any organ or any structure, especially in abdominal region, in GIT, you have to notice that two components are there, sympathetic and parasympathetic components. Sympathetic. Now in case of sympathetic and parasympathetic, both components, first of all you have to know the source from where the fibers are coming. Okay, and then if sympathetic is there, what is the function? If parasympathetic is there, what is the function? Okay, these are the points which I have mentioned last time. Don't forget those points. These are the key points. Okay, and same thing is being followed. Whatever we have discussed earlier, whatever we are discussing now, same thing is being followed. Okay, and I hope you have studied the nerve supply of stomach. If not, today we'll discuss about the nerve supply of stomach. At that time, we will see same two components are there, sympathetic, parasympathetic. From where the sympathetic is coming, from where the parasympathetic is coming, and then what are the functions. Okay, so same thing you can see over here. In case of nerve supply, so the nerve supply is mainly derived from cystic plexus, and the cystic plexus is derived from the hepatic plexus and the celiac plexus. Okay, now the cystic plexus which is there, it is a mixed plexus where it is having both sympathetic and parasympathetic components. Okay, now the lower part of the bile duct, okay, is supplied by the nerve plexus over the superior pancreaticoduodenal artery. Okay, the parasympathetic nerves which are there, mainly they are motor to the musculature of the gallbladder, but they are inhibitory to the sphincters. Okay, so the parasympathetic nerves which are there, first of all, they are motor to the musculature of the gallbladder. Okay, that means the nerve supply parasympathetic division will cause contraction to the smooth muscles of the gallbladder, but they are inhibitory to the sphincters. That means their nerve supply will close the sphincter. Inhibitory to the sphincter means it will close the sphincter. Okay. Next, the sympathetic nerves, they are coming from T7 to T9 segments of the spinal cord. Okay, and they are motor to the sphincters. So as I said, sympathetic, parasympathetic always functions will be opposite to each other. So here you have seen the parasympathetic is inhibitory to the sphincters. Okay, that means it will keep the sphincter closed. And in case of sympathetic, it will keep the sphincters open. Motor to the sphincters means it will open the sphincter. Okay, so like this always sympathetic, parasympathetic are opposite to each other. Okay, the function. Can't here. In case of nerve supply of extrahepatic biliary system, as I said, both the components are present, sympathetic as well as parasympathetic. Okay, now if you see the parasympathetic, what is the function? They are motor to the musculature of the gallbladder. That means whenever the parasympathetic nerve supply is there, the musculature of the gallbladder will contract. As a result, bile will come out. Okay, but they are inhibitory to the sphincters. Three sets of sphincters are there. Inhibitory to the sphincters means they will keep the sphincters closed. Next, in case of sympathetic, they are coming from T7 to T9 segment. They are vasomotor. Okay, that means they will increase the blood supply, and along with that, they are motor to the sphincters. That means they will help in opening of the sphincters. Okay, that is the concept of the nerve supply in case of extrahepatic biliary system. Now, have you heard about the term called referred pain? I hope you have heard about the term referred pain. You have studied also. Okay. Now, similarly, a very important clinical significance is they are related to the gallbladder. Okay. Now, what is that? Now, if suppose inflammation is there in the gallbladder, or suppose gallstones are there, okay, at that time, whenever pain is there in the gallbladder, so that pain can travel along with the vagus nerve, that is the parasympathetic part, sympathetic nerves, or along the phrenic nerves. These are the three pathways or three nerves by which the pain sensation can travel from the gallbladder. Okay. Now, in three different directions it is going, so the referred pain will be felt in three different areas. Okay. First of all, through vagus, the pain will be felt at epigastric region. Now, do you know what is epigastric region? Do you remember the quadrants of the abdomen? Yes. So in that quadrant of the abdomen, you know the epigastrium. Okay. I hope you know the quadrants of the abdomen. If you have not studied, please study the quadrants of the abdomen. Okay. So where is the epigastrium? This is the right hypochondrium. This is the left hypochondrium. This is epigastrium. Then what is this? Right lumbar, very good. Then what is this? Is left lumbar. Then this is umbilical region. Then what is this? Right iliac fossa. This is left iliac fossa, and this is hypogastric. Okay, so these are the quadrants of the abdomen. Don't forget. Now you are in abdomen. Okay, so whenever pain sensation is carried by the vagus nerve, at that time pain will be felt in the epigastric region. Okay, so that is also nothing but the referred pain. Next, through sympathetic nerves, okay, through sympathetic nerve. When it is traveling, the pain sensation, at that time pain will be felt at the inferior angle of right scapula. You have studied the scapula, right? So the inferior angle which is there on the right side, the pain will be felt. Okay, so there is also a type of referred pain from gallbladder. Next, T7 segments receive pain. Now there is a relation, because you have to understand the lateral horn of the T7 segments of the spinal cord gives sympathetic fibers to celiac ganglion through the greater sphingteric nerve. So when you will study the cut section of spinal cord, at that time you will come to know that it is having mainly two horns, but there are some areas where additional horn is there, that is called the lateral horn. Okay, so ventral horn is there, dorsal horn is there. Additionally, in thoracic region, another horn is there, that is called the lateral horn. From lateral horn, the fibers which are coming out, they are supplying the various viscera which is present in the abdominal region and the thoracic region. Okay, so I am talking about that lateral horn. Okay, so these fibers are going to the celiac ganglion. Now T7 segment receives pain fibers from the skin over the inferior angle of the scapula. Okay, so this is how the referred pain is felt in that particular area from the gallbladder. Next, through phrenic nerves. Okay, through phrenic nerve which is supplying the diaphragm, I hope you know. Okay, so the root value is C4. Okay, now that particular part, the superficial nerve which is coming out from the C4 segment is also supplying the skin over the right shoulder. Okay, so that's why the pain is felt in that particular area also. So like this, whenever problem is there in the gallbladder, these are certain areas where pain can be felt. Okay, and these are nothing but the referred pain. So problem is not there in the inferior angle of the scapula or over the right shoulder or in the epigastrium. Okay, the pain problem is in the gallbladder, and for that the pain is felt in those particular area, and that is the concept of referred pain. Okay, so that is all about the blood supply, nerve supply. Next, Calot's triangle. So last week I have shown you, right? So what is this Calot's triangle? So triangle means it is a triangular space. Okay, now it is formed between the cystic duct, common hepatic duct, and the inferior surface of the liver. Okay, cystic duct, common hepatic duct. Okay, cystic duct, common hepatic duct, and the inferior surface of the liver. In between them, a triangular area is formed, and that is called the Calot's triangle. Okay, now if you see the Calot's triangle, it is enclosed by double layer of peritoneum, and sometimes it is acting as mesentery of the cystic duct. Okay, means the triangular space which is there, in that mesentery is present. Now the two layers which are very closely placed, okay, that's why appreciable amount of loose connective tissue are present in that particular area. Okay, now inside the Calot's triangle, some important structures are present, and as you can see, what are those structures? Cystic artery is there, cystic lymph node, lymphatics from the gallbladder, okay, small cystic vein, and autonomic nerves running to the gallbladder. These are some important structures which are present inside the Calot's triangle. So the most important structure which is present inside the Calot's triangle is cystic artery. Okay, is cystic artery. Now we'll see the clinical significance, why it is important, why we have to study particularly about the triangle. Okay, now whenever the cholecystectomy is done, what is cholecystectomy? Surgical removal of the gallbladder. When the cholecystectomy is done, at that time care has to be taken so that the bile duct, okay, or cystic duct or the hepatic duct should not be ligated. Whenever the gallbladder is removed, at that time ligation of the cystic artery should be done, or else there will be bleeding from the cystic artery, right? So because of the variation of the codes in cystic artery and the cystic duct, okay, the care has to be taken so that the ligation should be done in case of cystic artery only, not for the cystic duct and the hepatic ducts. Okay, so that is the most important clinical significance of the Calot's triangle. Now here you can see the diagram of the Calot's triangle. Okay, so this you can see, this is the undersurface of the liver. And from here we are getting the cystic duct, and this is the common hepatic duct. So in between this, can you see a triangular area? So this is the Calot's triangle. Okay. Now in the Calot's triangle, cystic artery is there, cystic vein is there, then lymphatics are there coming from the gallbladder. Okay. But the most important content is nothing but the cystic artery. Okay. And as I said, variations are there. The cystic artery, okay, I will show you the different ways the cystic artery is traveling in order to supply the gallbladder. Okay. So identifying the variation and ligating the cystic artery is very important in the Calot's triangle while doing the cholecystectomy. Okay, cholecystectomy is the surgical removal of the gallbladder. Now here you can see the variation of the cystic artery. Okay, different types of variations are there. So first you can see infracystic. So this is the right branch of the common hepatic artery from which the cystic artery is arising. So in this case, just see the direction of the cystic artery. Okay, so this is infracystic. Now here this is paracystic. Okay, that also posteriorly. Here it was anteriorly. Now here it is posteriorly. Means posterior to the common hepatic duct. Next, here you can see. So this is the common hepatic duct. Right and left hepatic duct will join the common hepatic duct. So it is supracystic. Okay, means above the cystic duct. Just see the variations. Okay, so that's why I have mentioned that variation should be known, or else what will happen? The cystic duct and the common hepatic duct will be ligated. If they are ligated, what will happen? There will be obstructive jaundice for that patient. Okay, and if the artery is not ligated, huge bleeding will be there. Okay, that's why knowing the variation is important. Okay, next in this case infracystic. So here infracystic, that also posteriorly. Then here paracystic, posterior, but you can see two lumps are there. Here one lump, another, here another lump. Okay. Next paracystic, posteriorly, single hump is there. This is the single hump. Here two humps you can see, but here single hump. Okay, so like this there are variations in the course of the cystic artery. Okay, so before doing the cholecystectomy, this particular knowledge should be there, so that the cystic artery should be ligated, not the cystic duct and the common hepatic duct. Okay. Next, the variation is not only present in case of a cystic artery. Variations are also there in cystic duct also. Variations are present in cystic duct also. Now here you can see the variations of the cystic duct. Can you identify the cystic duct? Everyone, can you identify the cystic? How will identify the cystic duct? First you have to identify the gallbladder. As simple as that. Can you identify the gallbladder in the diagram? Everyone. So this is the gallbladder. From here you can see the cystic duct which is coming and joining. Okay. That is almost normal in an acute angle with the common hepatic duct. Now here you can see absence or very short cystic duct. You can see cystic duct is very short. Now the union is not at acute angle. Okay, you can see union is not at the acute angle. Now drains into the right hepatic duct. You can see it is going into the right hepatic duct, cystic duct. Okay. Now here also you can see union is very low. Now here you can see parallel to the cystic duct. Then here you can see spiral union of the cystic duct. Okay. So like this, as you can see in the diagram, the variations are there in cystic duct also. Okay, so that's why this variation along with the variation of the cystic artery is important. The knowledge is important before doing the cholecystectomy. Okay. Next, can anyone identify what is this? Everyone please look at the image carefully. Can you identify what is this? See, from last week onwards we are studying about the extrahepatic biliary system, right? Now extrahepatic biliary system, suppose any blockage is there in the extrahepatic biliary system, you want to know in which area the blockage is present. In that case, what you will do? You can't take out the entire hepatic system from a person, not possible. For that, what you will do? For that, there are different radiological examination by which we can identify. First of all, we can see the patency of the ducts and we can identify whether any blockage is present or not. Okay. Now, different radiological examinations are there. For example, with the help of X-ray, we can identify the parts of the extrahepatic biliary system. Okay. In that case, that particular investigation is called as cholecystography. Okay. Cholecystography. Okay, so cholecystography is a radiological examination in which the contrast media is given, and then with the help of the fluoroscopy, the images of extrahepatic biliary system are produced. Okay, to see the patency as well as to see whether any blockage or any other pathology is present or not. Okay, now this cholecystography is also of various type. For example, oral cholecystography is there, where the contrast media is given through oral route. IV cholecystography is there, where contrast media is given through intravenous route. Okay, like these different types of cholecystography are there. Next, as you know, the medical science is advancing. Okay, so in MRI, another technique is there by which we can identify those structure, and that investigation in MRI, it is called as MRCP. MRCP. Now this is the MRCP of extrahepatic biliary system. What is the MRCP? Magnetic resonance cholangiopancreatography. MRCP, magnetic resonance cholangiopancreatography. That means the extrahepatic biliary system will be visible. Along with that, the pancreatic ducts will also be visible. That is the advantage of MRCP. Okay. In cholecystography only you can see the extrahepatic biliary system. You can't see the pancreatic duct. Okay. But with the help of MRCP, means with the help of MRI, okay, you can see the extrahepatic biliary system. Along with that, you can see the pancreatic duct also. That's why it is called as MRCP. Okay. So this is the MRCP, and you can see the appearance of the MRCP. Okay, where you can see the common bile duct. Okay, you can see the gallbladder. This is the cystic duct. These are the hepatic ducts. Okay, this is the common bile duct, and you can see the pancreatic duct also. Okay, and you can see they are joining in and draining into the second part of the duodenum. Okay, so this is how normal MRCP image appears. Okay, this is the normal MRCP image. Next to that, can you see another image is there, and that is called as ERCP. So what is this ERCP? It is, here we don't use MRI, we are using X-ray only, but the way of giving contrast is a bit different. Okay, and that's why it is called as ERCP. Okay, that is endoscopic retrograde cholangiopancreatography. Endoscopic, that means the endoscope is inserted. Okay, and through that endoscope, the catheter will be inserted. It will be advanced up to the second part of the duodenum under fluoroscopy guidance. Then the contrast media is injected at superior papilla or major duodenal papilla, through which the contrast media will flow in a opposite direction, in a retrograde flow, in a retrograde manner. That's why it is called as ERCP, endoscopic retrograde cholangiopancreatography. Okay. Now here you can see this is the endoscope. Okay. Now endoscope is what in this particular area, and after that through the with the help of the catheter, the contrast media is injected. Now once the contrast media is injected, it will flow in opposite direction. That's why it is called as retrograde. Okay, generally the bile is coming and draining into the duodenum. Now here from duodenum, the contrast media is going in opposite direction. That's why it is called as retrograde. Okay. Now with the help of this study, we can also see the patency of the common bile duct and the pancreatic duct. Okay. So this is also a examination done in order to see when the oral cholecystography or IV cholecystography fails. Okay. That means this cholecystography, if it is failed to delineate the structures of extrahepatic biliary system, in that case the ERCP is done. Okay. And more advanced technique are also available, and that is the MRCP, where you don't have to insert anything, you don't have to give anything. Just directly with the help of MRI, you can produce the images. Okay, so these are some advancement taken place for better diagnosis. Now here you can see the endoscope. As I said, the endoscope is inserted. As you can see, it is coming through the duodenum. Now this is the second part of the duodenum at a major duodenal papilla. Okay, and that can be visualized with the help of fluoroscopy. Okay, so the guidance is taken, and inside the endoscope a light source is there and a camera is there. Okay, so that can be seen in the monitor. Once the major duodenal papilla is reached, after that the catheter, as you can see, the catheter is inserted, and with the help of the catheter the contrast media is injected. Okay, so when the contrast media will be injected at the major duodenal papilla. Okay, at that time the contrast will flow in a opposite direction in both the duct, that is the common bile duct and in the main pancreatic duct. Once the contrast media is flowing, that can be seen under fluoroscopy, and then series of X-rays are taken. So if any blockage is there, if any stricture is there, that can be diagnosed easily. Okay, as you can see in this diagram. Okay, so if any blockage is there due to the gallstone, that can also be diagnosed easily. Okay, so that is the ERCP, endoscopic retrograde cholangiopancreatography. Okay, so we'll go to the next. Now here you can see a gallstone is there, which is lodged into the common bile duct, and it is obstructing the common bile duct. Okay, now in that case also, patient may suffer from jaundice, and it is called as obstructive jaundice. Okay, and in those cases, this particular ERCP is gold standard. Means we can exactly identify what is the location of the blockage. Either single blockage is there or multiple blockages are there. That can also be identified with the help of this study. Okay, that's why they are very important. Okay, next about the jaundice, already you know what is this jaundice. That is a clinical condition where the color of the skin, sclera, and the exposed part of the mucous membrane becomes yellow. Okay, due to the excess accumulation of free conjugated bilirubin in the blood. Okay, now normal bilirubin level, as you can see, it is 0.5 to 1.5 mg per deciliter of blood. When it exceeds 2 mg per deciliter of blood, at that time it is called as jaundice. Okay, three different types of jaundices are there. That is the pre-hepatic, hepatic, and post-hepatic. Okay, so pre-hepatic and hepatic mostly they are related to liver. In case of pre-hepatic, mainly hemolytic jaundice is there. That means destructions of the RBC takes place. Okay, in case of hepatic or hepatocellular, mainly there will be damage to the hepatic cells, the hepatocytes. Okay, and here the post-hepatic is the obstructive one, which I have shown you just now. Okay, so in and this is related to the extrahepatic biliary system. The post-hepatic or the obstructive jaundice is related to extrahepatic biliary system, because in that case the obstruction is present in the extrahepatic biliary system, some part of the extrahepatic biliary system. Okay, how we will diagnose? For that, already I mentioned the steps, I mentioned the procedure. MRCP is there, ERCP is there, cholecystography is there. Okay, these are the various techniques by which we can identify the obstructive jaundice. Means what is the reason behind the obstructive jaundice, where the obstruction has been taken. Next, there are some other important terminologies related to the extrahepatic biliary system. Okay, first of all, inflammation of the gallbladder is called as cholecystitis. Already you know that. Okay, now whenever a patient is suffering from cholecystitis, at that time what will happen? The patient will suffer from pain. Okay, complains pain, that also in which area? In right hypochondriac region. Okay, patient will feel pain in right hypochondriac region, and it will radiate at towards the inferior angle of right scapula. Okay, this is the direction of the pain which will radiate. Now when the finger is placed just below the right costal margin, that also at the tip of 9th costal cartilage, and when you will ask the patient to take deep breath, at that time patient will feel severe pain, and that is called as Murphy's sign. That is called as Murphy's sign. Last class I have told you where is the exact location of the fundus of the gallbladder, surface anatomy of the fundus of the gallbladder. In the last class we have discussed. Okay. Now when cholecystitis is there in the gallbladder, inflammation, at that time pain is there in the right hypochondriac region. Okay. Now in order to diagnose it, what you will do? You will put the hand on the right costal margin, that also at the tip of 9th costal cartilage, and you will ask the patient to take a deep breath. Now when the patient will take a deep breath, at that time patient will feel severe pain, and you can see the painful expression on his or her mouth, and that is called as Murphy's sign. Okay. Next, the stone which is there inside the gallbladder, that is responsible for spasmodic contraction in the gallbladder, and that is called as biliary colic. Okay, if anyone in the classroom have suffered from gallstone, then that person will understand. Okay, at the time what happened? There will be spasmodic contraction in the musculature of the gallbladder, and that is called as biliary colic. Next, the surgical removal is called as cholecystectomy, and the gallstone which are there, these are nothing but the solid crystal deposit in the form of cholesterol, calcium ions, bile pigments, okay, in the gallbladder and in the bile duct. Okay. Now, if the gallstone are present inside the gallbladder, then it is called as cholelithiasis. Okay. As you can see, it is called as cholelithiasis. And choledochal means presence of the gallstone in the bile duct. These terminologies are important because as you will go into the higher semester, at that time these terminologies will be used. Okay, so that's why it will be better if you know the terminologies from now onwards. Next, here are some ultrasound images. Okay, two ultrasound images are there. As you can see, this is the portal vein, this is the hepatic artery, and this is the common bile duct. Now here you can see this is the normal common bile duct under ultrasound appearance. Okay, so this is how the appearance of the normal bile duct takes place. Okay, now if there is any stone in the common bile duct, that can also be diagnosed with the help of ultrasound. Okay, and you can see this is the appearance. Okay, so hyperechoic structure will be there. Okay, because the stone is having higher tissue density as compared to the duct and the liver. That's why it will be hyperechoic, and posterior acoustic shadowing will also be present posterior to the stone. Okay, so this is the identifying feature. Okay, when stone is present inside the common bile duct. Okay, so see, today I have shown you the image of MRI also, MRCP. Then I have shown you the ERCP images, X-ray images, and see now I am showing you the ultrasound images. Okay, so these are some important investigation which can be done, and with the help of that, whether stone is present or not, whether the duct is dilated or not, okay, in which part exactly the stone is located, all those things can be diagnosed. Okay, these are specifically because for the cause of diagnosis. So that is all about the extrahepatic biliary system. Now here you can see the Morphy's sign. Already I have told you what is the Morphy's sign. When you will put the hand over here at the tip of 9 costal cartilage, okay, and ask the patient to take a deep breath. At that time, patient will feel severe pain in that particular area, and that is called as Morphy's sign. Okay. So that is all about the extrahepatic biliary system. Okay. Next, we will start with the stomach. I know you have studied in the dissection hall about the stomach. Okay. So I will not go in detail about the gross anatomy of the stomach. Okay. Two important things which I would like to discuss about the stomach. Okay. That is the nerve supply as well as the lymphatic drainage. Okay. Now, why exactly the nerve supply and the lymphatic drainage? Any idea? Have you studied the lymphatic drainage? Those upper 2/3, right 1/3, left 1/3, like this. Have you studied about the lymphatic drainage of the stomach? Anyone? Please keep that in mind whenever I am focusing or anything is mentioned about the lymphatic drainage. That means it is helping in during metastasis. That means whenever the carcinoma are there in the stomach, with the help of the lymphatic, it can spread to the other parts. That's why the lymphatics are very important in case of stomach or in case of the organs, whatever we have discussed. Next, in nerve supply, why it is important? In nerve supply, why it is important? Have you heard about the vagotomy? I know you have studied about the vagotomy also. Okay, so in order to understand the vagotomy, first you have to understand the nerve supply of the stomach. Okay, again in case of stomach also two divisions are there, sympathetic and parasympathetic division, which is supplying the various part of the stomach. Okay, and the vagotomy is the clinical significance of the nerve supply of the stomach. Okay, these things are very important. Whenever I am mentioning, please note it down. Okay, from there only the questions will be asked in the exam. Okay, what is vagotomy? What are the different types of vagotomy? Okay, or what is the clinical significance of the nerve supply of the stomach? These points are very important. Okay, so in stomach, right, for example, fundus of the stomach, okay, body of the stomach, then lesser curvature of the stomach, greater curvature of the stomach. So here you can see the parts of the stomach, and already you have seen all those things during this section. Next, have you seen the interior of the stomach? Interior of the stomach, this one? Yes. So you know what are gastric rugae, then gastric pits, gastric canal. right? So all those things you have discussed, you have studied. Okay, so we'll not go in detail about this. Now this is the structure showing the interior of the stomach, where you can see the gastric rugae are there. In between the gastric rugae, gastric pits are there. Deep to the gastric pits, gastric glands are situated. Okay, and gastric rugae are absent in case of lesser curvature. So whenever you are drinking any liquid, okay, through gastric canal it is passing, or it is flowing through the gastric canal. Okay, as you can see the gastric canal. This is also a reason why the ulceration are more common in the lesser curvature of the stomach. Okay, so there are some liquid, okay, or there are some fluid which are irritable to the gastric mucosa. Best example is alcohol. Okay, so alcohol is irritating for the gastric mucosa. So whenever a person is consuming alcohol, at that time it is tend to pass through this particular gastric canal. Okay, so when it is passing through the gastric canal continuously, repeatedly, it will irritate that mucosa. Okay, and it is not spreading in the other part. So every time when the liquid is irritating that particular mucosa, gradually it will develop to ulcer. Okay, so it is also a reason why ulceration is common in the lesser curvature of the stomach. Okay. Now, before going to the ulceration, different types of ulcer, as I said, first we'll discuss about the lymphatic drainage and the nerve supply of the stomach. Very important, because they are having important clinical significance. So I'll start with the lymphatic drainage. So in case of lymphatic drainage, in case of stomach, three sets of intercommunicating lymphatic plexuses are there. Okay, 3 sets of intercommunicating lymphatic plexuses are present in the stomach. Okay, now these are submucous, intramuscular and subserous. These are intercommunicating lymphatic plexuses which are present. Now the lymphatics begins from the subepithelial lymphatic radicals. Okay, subepithelial lymphatic radicals, from there the lymphatic begins. Okay, which are blind and at this particular level, and then they are forming the periglandular plexus. Okay, next the efferents from that particular plexus will pierce the muscularis mucosa. Muscularis mucosa is a layer of the stomach. Okay, muscularis mucosa is a layer of the stomach. Okay, from the submucous plexus, and then the outgoing vessels from this plexus will successively intramuscular and subserous plexus. Okay, will form this particular plexuses. Okay, so beginning is at the subepithelial lymphatic radicals. Gradually they are successively forming the intramuscular and subserous plexus. Okay, next what happen? The collecting vessels from this subserous plexus will accompany the blood vessels which supplies the various part of the stomach. Okay, and drain into the various groups of the regional lymph nodes or the adjacent lymph nodes which are present around the stomach. So the lymph from the upper left 1/3 of the stomach drains into the pancreatico-splenic lymph node. Okay, so for to make it easy, the imaginary divisions are done of the stomach. Okay, so that the lymphatic drainage can be understood easily. Okay, so in doing that, first of all, left 1/3 is there. So the left 1/3 will drain into the pancreatico-splenic lymph nodes. Okay, will drain to the pancreatico-splenic lymph nodes which are situated along the splenic artery. Okay, and from there ultimately it will go to the celiac nodes. Next, right 2/3 drains into the left gastric nodes, and lymph from those nodes will go to the celiac nodes. So just follow one thing. In every case, celiac nodes are common. Okay, you can see from here also it is ultimately going to the celiac nodes. From right to third, first it will go to the left gastric, and there it will go to the celiac nodes. Okay. Next, the lower part of left 1/3, okay, drains into the right gastroepiploic. From here the lymph will drain into the hepatic, and then finally it will drain into the celiac nodes. Okay. Next, the pyloric part drains into different direction. Okay, into the pyloric, hepatic, and then left gastric. This is the direction of the flow of the lymph. Okay, and ultimately it will reach the celiac nodes. Okay, so in every case you have seen that from various part of the stomach, the lymphatics which are drained, it will go to the celiac nodes. Okay, ultimately it will reach the celiac nodes, and from that it will reach the intestinal lymph trunk, and from intestinal lymph trunk it will go to the thoracic duct. Okay, cisterna chyli, and from cisterna chyli it will go to the thoracic duct. Okay, this is how the lymphatic drainage of the stomach is taking place. Now in this diagram, as you can see, okay, so from here it is going to the pancreatico-splenic. Okay, then from here, as you can see, the lower part, right gastroepiploic. Okay, so these are the pyloric nodes. From there it is going to the hepatic nodes, and ultimately, as you can see, they are draining into the celiac group of lymph nodes. From celiac group of lymph nodes, intestinal lymph trunk, from intestinal lymph trunk cisterna chyli, and from cisterna chyli through thoracic duct it is going out. Okay, and as I said, thoracic duct is the largest lymphatic vessel of our body. Okay, next is the nerve supply. Now in case of nerve supply also, two divisions are there, same like the previous one, whatever we have discussed. Okay, sympathetic and parasympathetic. Now here the parasympathetic innervation, from where they are coming from anterior and posterior vagal trunk. Okay, anterior and posterior vagal trunk. So these are nothing but the left and right vagus nerve respectively. Left and right vagus nerve respectively. The vagus nerve is nothing but the 10th cranial nerve. Okay, vagus nerve is a 10th cranial nerve. Now the anterior vagal trunk mainly supplies a portion of the anterior surface of the stomach as well as the pylorus. These are the areas which are supplied by the anterior vagal trunk. Now posterior vagal trunk will supply the remaining anterior surface as well as the entire posterior surface. Okay, this is how the nerve which divides and then supplies the various aspects of the stomach. Okay, now the question is, what is the function? So parasympathetic innervation is responsible for gastric secretion. That means whatever the gastric juice is secreted, okay, so that is done by the parasympathetic division. Okay, and motility, okay, that means it will increase the motility as well as it will relax the pyloric sphincter during the gastric emptying. So it will help in gastric emptying. It will relax the pyloric sphincter. I hope you have seen the pyloric sphincter in dissection hall. If not, please go and see the pyloric sphincter. Okay, so this parasympathetic division will help in opening of the pyloric sphincter as well as it will help in emptying of the gastric content so that it can go into the duodenum. Next, the vagus nerve also carries the sensation of pain, okay, then fullness and nausea from the stomach. So suppose you are having breakfast or lunch, after a certain period of time if you feel that no, I am full, I can't take much, okay, so that satisfaction, that is carried, that sense is carried by the vagus nerve, and then pain, sensation, nausea, those are also carried by the vagus nerve. Okay, next is the sympathetic division. Now sympathetic division is provided by the celiac plexus. Okay, now here the fibers are coming from T6 to T9 segment of the spinal cord, okay, and from the greater splanchnic nerves. The sympathetic innervation is responsible for inhibiting the gastric motility. Okay, that means the movement which is the peristalsis movement, it will inhibit the movement. Okay, so just compare, it will be opposite to the parasympathetic division. Next, it will constrict the pyloric sphincter, thus preventing the gastric emptying. Means it will delay the gastric emptying. So whenever you are eating something, okay, eating food, when it goes to the stomach, directly it will not go to the duodenum. It takes time, and that also it depends which type of meal you have taken. Okay, because if it is carbohydrate rich food, then less time is taken in order to open the gastric the pyloric sphincter. If the food is full up of fat or protein, at that time more amount of time is taken. In case of fat, the time taken is approximately 3 hours, okay, to complete the other digestion, and then it will go to the duodenum. Okay, so that time is required, okay, and that is provided by the sympathetic division, which will delay the gastric emptying. Okay, now another important point is there, that is the nerve to lateral jet, which is a important branch. Okay, the nerve to lateral jet, I don't know whether you have heard or not. It is a branch of both anterior and the posterior vagal trunk. Okay, and it is present on the anterior surface also, it is present on the posterior surface also. Okay, of the lesser curvature. Okay, anterior surface, posterior surface, both of the lesser curvature of the stomach, and it is coming from the both vagal trunk, anterior as well as posterior vagal trunk. Okay. Now the fibers which are coming, they are supplying the pylorus of the stomach, as well as they are also supplying the glands which are secreting. They are supplying the glands which are secreting various enzymes or various other materials in the stomach. Okay, and that is very important because it is cut, this particular nerve to lateral jet, it is cut in selective vagotomy and preserved in highly selective vagotomy. Okay, so this particular nerve is cut during the time of vagotomy. Now it functions by increasing peristalsis, relaxing the sphincter, and thus draining the content of the stomach into the duodenum. So this is the main function of the lateral jet. Now the question is, when the nerve is having such an important function, why we have to cut that particular nerve? Vagotomy means you are cutting that particular nerve. Okay, so the nerve is having such important function, why we have to cut? Because see, there are some cases where when a person is suffering from ulcer, okay, when a person is suffering from ulcer, the doctor has given different medicines, different drugs, but it is not acting. Okay, at that time the secretion has to be reduced. If the secretion is not reduced, then the ulcer will not heal. Okay, it will get worse. So in order to stop the secretion, the vagotomy is done. Okay, so once you cut the nerve which is supplying the area or the supplying the glands which are secreting, at that time what will happen? The secretion will not take place. As a result, the amount of secretion will get reduced, and then the time will be there for healing. That's why the vagotomy is important. Okay, so 3 different types of vagotomies are there. Okay, now this is the diagram. Before going to the diagram, let me show you. This is the diagram for the sympathetic nerve supply of the stomach. Can anyone tell me what is this? This is the cut section of the spinal cord. Okay, this is the cut section of the spinal cord. Okay, this is the ventral horn, this is the dorsal horn, and this is the lateral horn. Okay, like this different horns are there of the spinal cord. So the fibers which are coming out, okay, ultimately they will mix to form the mixed nerve. Okay, and then here gray ramus and white ramus communications are there. Okay, these are nothing but the pre and post ganglionic fibers in case of the sympathetic nerve supply. Okay, then you can see the fibers are coming to the post ganglionic fibers are coming to the celiac plexus, and from celiac plexus they are supplying the stomach. Okay, and whenever the sensory nerves are going, always they will go through the posterior route. Okay, that's why the DRG is there, that is also called as dorsal root ganglion. Okay, these things I know you will not understand right now. Once we will discuss the spinal cord, at that time things will get clear. Okay, next, this is the nerve supply of the stomach parasympathetic division. Okay, as you can see, the nerve to lateral jet are present in both anterior as well as posterior surface of the stomach. Okay, now as I said, 3 types of vagotomy are there. Okay, now section of the vagal trunk, also called as vagotomy, performed to reduce the production of HCl from the parietal cells. Okay, in which the patient is suffering from gastric ulcer or ulcer of the duodenum. In order to get the healing fast, this particular surgery is done, and that is called the vagotomy. Now 3 types of vagotomy are there: truncal vagotomy, selective and highly selective vagotomy are there. Okay, now what exactly happens? Now in case of truncal vagotomy, the main trunk of both the vagi are cut. Okay, both the trunk, anterior trunk also, posterior trunk also. That means there will be no parasympathetic nerve supply for the stomach. In that case, there are various problems occurring in the stomach. Okay, what will happen? Pyloroplasty is there. At that time, the destroying of the pyloric sphincter should be done. Okay. Now, post vagotomy diarrhea because of the damage of the hepatic and celiac branches. Okay, so like this, different other complication occurs in case of complete vagotomy. Another particular type is that is selective vagotomy, in which the nerve to lateral jet of both the vagi are cut. Okay, nerve to lateral jet. So in that case, what will happen? The major drawback is the mobility of the pyloric antrum and delayed in gastric emptying. Okay, this is also a complication of the selective vagotomy. Another type is that is called highly selective vagotomy, in which the fibers supplying that particular area which are secreting, those fibers are only cut. And after that, the pyloric branches are left undivided. The pyloric branches will not be separated. As a result, what will happen? It will not compromise with the mobility. Okay, that means only the secretion will be reduced, but the mobility remains same. Okay, so these are the different different types of the vagotomy. Okay, so we'll stop over here. There are some other important clinical aspects of the stomach, okay, that we'll discuss in the next class, especially about the ulcer of the stomach, and along with the ulcer, okay, gastric triangle and trough space. These are also two important clinical significance, okay, that will be discussed in the next class. Okay, thank you.